Hello everyone, this is Dr. Saroj Siddiqui from the platform of UKMLA with DSS, and the topic we're going to discuss today is the eating disorders. Okay, so before I start discussing the details of the two eating disorder, that is the anorexia nervosa and the bulimia nervosa that usually shows up in the exam, I would like to clear the concept of what the eating disorders are. Okay, so let's just have a look at this. A person that is eating normally, okay, they have got no eating disorders. Okay, somebody like you and me who are just normally eating, we have got no eating disorder. Okay, then there is a person who is eating way more than usual. Okay, like what we call as overeating. Okay, they keep on eating, they keep on eating, they keep on eating, okay, without any guilt. Okay, and because of eating a lot, they may end up gaining a lot of weight as well. Okay, so if somebody is eating without any guilt, that is called binge eating. Okay, so the people who binge eat, they you may find them like morbidly obese and overweight, and you may find them very very fat. Okay, but there is a type of person who has some psychiatric issues and something related to the food, and that particular case is the bulimia nervosa, in which the person eats a lot. Okay, they just want to eat, they just want to eat as much as they can, but at the same time they're eating with the guilt, that okay, I shouldn't have eaten it, I shouldn't have eaten that hamburger, I shouldn't have eaten that pizza, I shouldn't have drink that can of Pepsi. Okay, so if somebody is eating and like constantly eating, overeating with the guilt, okay, then we call that condition as bulimia nervosa. All right. So somebody who is eating with guilt, okay, so they would do something or the other that would help them cope up with their guilt mechanism. Okay, and what they do is that they try to reverse, and they try to take out the food that they're eating. Okay, like for example, they may end up inducing vomiting, they may end up going on laxatives, and they may end up doing over exercises. Okay, just to make sure that they can reverse the amount of food that they've eaten. Okay, so the patient of bulimia nervosa will not always be obese. Okay, will not always be very very fat, but not always be overweight. Okay, so the bulimia nervosa patient can also be thin and lean. Why? Because they eat a lot, but they end up just taking away and taking out all the food that they have consumed. Okay, so that is the difference between the binge eating and the bulimia nervosa. All right, both of them would be eating a lot, but one of them would be gaining weight because they wouldn't have any guilt. Okay, they just keep on eating, keep on eating, keep on eating. But the patient of bulimia nervosa would have a lot of guilt, and that's why they would be doing something or the other just to take the food out of their body, and therefore they wouldn't be gaining any weight. Okay, so that is the concept that I wanted to make clear in your head. Okay, then comes a person who is eating less than normal. All right. Somebody who is going on extreme diets. Okay. Somebody who's taking extreme measures to make sure that they don't gain weight. Okay. And how they do that is that they stop eating. Okay. They go on extreme diet. They go on like a very very healthy food, but to a point that they try to go in a very severe caloric deficit. Okay, and we call those patients as anorexia nervosa. Okay, so now you have the concept, and now the concept of bulimia nervosa and anorexia nervosa is clear in your head. Okay, let's just move on to the structures. Okay, and how a particular case would present. Okay, let's just begin with anorexia nervosa. So the anorexia nervosa case, okay, most likely you're going to have a young female who would be brought by her mom, or maybe if she's not brought by her mom, maybe she might be brought by a relative. Okay, but there would be someone who would be bringing her. And why? Because these people, they don't have the insight, they don't think that okay, they're eating very less and they're losing weight very rapidly, and they're getting thin, they're getting lean, they're getting weak. Okay, they don't think all of these things as problems. Okay, so they would be brought in by someone. Okay, most likely their mother or their relative or their father. Okay, so one thing that you need to like identify. Okay, then the BMI would be given very very low. Okay, In the case of anorexia nervosa, it is most likely to be less than 17.5. Okay, and her mother would be worried about the fact that she's not eating well. Okay, so the complaint that the mother may give are two complaints basically. That number one, she is not eating well. Okay, and number two, that she has lost some weight. Okay, so if you ever find a young lady brought by mother with a complaint of weight loss and not eating well, you should automatically know that okay, this cannot be anything other than anorexia nervosa. All right, so the case note would be very much self-explanatory. All right, if it's not written, if this much information is not written in the case notes, then you're going to ask about that. Okay, do you have any concerns? What concerns do you have about your daughter? Then the mother is herself is going to say that doctor, yeah, she's not eating well, or doctor, she's losing some weight. All right, so you have to then begin your history in that way. Okay, so the first layer that you need to make sure and that you need to have in your mind when you're discussing and when you're exploring anorexia nervosa is the presenting complaint that okay, weight loss and not eating anything. Okay, so you need to explore that. Okay, and how you're going to explore that? Okay, that since how long she have not been eating, how much weight has she lost, is she not eating intentionally, is she no, or is she not eating unintentionally, okay, how is the weight loss, is the weight loss intentional, is the weight loss unintentional. Okay, and then you would also ask a few questions just to rule out a couple of differentials of weight loss. Okay, and just 2 to 3 differentials should be more than enough. You can just ask about thyroid and how you're going to ask about that. Okay, does do you have any heat or cold intolerance? Okay, do you have any changes in your mood? Okay, that would help you rule out depression. And then you can just ask about do you have any lumps and bumps anywhere in the body, or have you experienced any a fever or flu like illness recently. Okay, just to make sure that you're not just directly sounding scripted and you're not just directly going on to anorexia nervosa. You're just being a safe doctor. You're just trying to rule out the differences. You're just trying to touch upon the differences as well. Okay, so just a couple of questions. All right, then very important thing, since it's a psychiatry station and this particular patient, she would be kind of depressed. Why? Because she may be thinking that I am very fat, I'm gaining a lot of weight. Okay, and therefore she would give you some hints by her body language, which we call as the non-verbal clues. Okay, she would be looking a bit shy, she would be sounding a bit anxious, and she would be looking a bit underconfident. Okay, so again, whenever you see those non-verbal clues, you know what to do. Okay, you need to be extremely supportive. You need to acknowledge the fact that okay, okay, Elena, I can see that you're not being yourself. I can see that you're being uh, uncomfortable. I can see that something is bothering you right now. But let me tell you that this is a safe space. Whatever you discuss here and whatever we talk about would remain confidential. And I'm here to help you, and I'm going to help you in the best way I can. Will it be okay if we can just ask a couple of questions? Okay, but despite that, the patient would keep on saying that doctor, there is nothing wrong with me. Doctor, there is nothing wrong with me. I'm not losing any weight. There is nothing, no problem with eating that is associated with me. It's just my mother who thinks a lot. It's my mother who just wants to make my life difficult. That's why she's constantly taking me to the GP surgery, constantly taking me to a doctor. Okay, so you got to be more diplomatic and much more smart. Okay, if the patient is not opening up to you, if the patient is not answering all your questions, then try to use the situation as I taught you in the schizophrenia case. Like for example, her mother has brought her, right? So what you can say that okay, if you're just able to answer a few questions for me, then I'm going to make sure that I talk to your mother and explain it to her that everything is okay with you, so that your mother doesn't bother you anymore. Okay, try to use situation like this. Try to use words like these, and try to play with the situation to make it better for you, to make it much more easier for you to do your data gathering and proceed with the session basically. All right, So it's a thing that you would have to practice, and it's a thing that you would have to master. All right. So yeah, you can do it other way. You can either open up and discuss the non-verbal clue after exploring the presenting complaint. If the patient is slightly receptive and if the patient is slightly answering a few questions, and you can do it like later on as well after you've explored the presenting complaint, when you are actually going to the layer that is like the most important when it comes to the eating disorder scenarios. Okay. So yeah, the next layer, like it's very important, the diet, because that is what the problem is. The mother is concerned about the fact that she's not eating well. Okay. And after you have made the patient comfortable, after you have provided the patient with a safe space, then you can get into more details of the situation, and then the patient may become much more comfortable in answering your questions. Okay. And how you're going to explore the diet? Number one, you're going to ask about that. Okay, can you please walk me through your diet? Like, what do you eat for breakfast? And then she's going to say that, yeah, doctor, I just take a cookie and I just drink some hot coffee. That's it. Okay, then what do you eat for your lunch? Yeah, doctor, in my lunch I just have a couple of bites of salad. All right. And then what do you have for dinner? Yeah, doctor, my dinner is usually light. I just like to take some fruits and a glass of juice, and that's it. So you would know that, okay, she's eating really, really less. Like the diet that I just explained to you in the answer, you could see that, okay, this is not adequate enough. This is not something that would complete her caloric requirement. Okay. So you would get the idea that okay, she is not eating properly, she is deliberately losing her weight, and she is not eating as per her caloric requirement. Okay. And then you're going to further explore, okay, the diet aspect, that okay, Elena, can you just tell me whether or not you try to skip meals? And then she may again kind of get uncomfortable, and she may not open to no doctor, no doctor, I don't skip meal. But then again you would have to be very, very reassuring that, well, and I told you that this is a safe space. It's completely okay to talk about it, and if you would just discuss it, your condition with me, if you're able to answer all my questions, I would be able to help you in a better way. And then she would say, yeah, doctor, I often end up skipping my meals. Okay. And then you would ask, do you avoid sugar in your diet? And then she would say, yeah, doctor, I completely avoid sugar. I go for diet juice. I do not put any sugar in my coffee. I avoid taking pastries, avoid eating ice creams, and avoid eating cakes. All right. And then you're going to ask about that, do you refrain from eating out? Okay. So these people, they have the habit of not eating outside. They avoid fast food. If their family is going out somewhere to dine out, then they would avoid that. They would not go to that particular hangout spot, or even if they go over there, they wouldn't eat anything, or they would order something very, very light and something very, very low on the calorie. Okay. So these five set of questions, okay, it's like really, really important to explore that diet, because that is where the main problem lies. Okay. And whenever the patient gets uncomfortable, you know how to reassure the patient and how to make sure that the patient starts talking to you, because this is something that is going to happen. Okay. At one point they would get comfortable, answer a few questions, and then again they would go back again on their defensive posture, and defensive mode, in which they don't want to answer any questions. Okay. Yeah. Then another very, very important aspect, you should remember this. This is called the scoff. Okay. And in all the eating disorder questions, you need to ask about the scoff. Okay. I'll tell you what the scoff is and what answer they would give you for each question. Okay. So there are five set of questions in the scoff part. Okay. The first question, the S stands for sick. Okay. Do you make yourself sick? Okay, they would say no. Okay, what does that mean? That, okay, are you trying to intentionally vomit? Do you take some laxatives? Okay, or do you like do those things that will result you in throwing up, or going to the washroom, causing excessive diarrhea? Okay. They would say no to it. Okay, because they don't have any tendencies like this, and patient of anorexia nervosa would not be making themselves sick. Okay. Then C stands for the control. That, do you feel that you have lost the control over your eating habits? Okay. and they would say yes, because even though they are not overeating, even though they have a very 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 strong control on their eating habits, but still, they would think that they're eating too much, and they should lose more weight, and they would think that okay, they have lost the control over their eating habits. Okay, then you gotta ask about the O part. Okay, what does the O part stands for? The one stone weight. Okay, so how you going to frame that? That have you lost more than one stone weight in 3 months? One stone weight means up to 6 kilogram in 3 months. Okay, and the answer would be yes. Why? Because the patient of anorexia nervosa keeps on losing weight. Okay, they don't exercise, they don't eat enough. Okay, and they also do some heavy exercises as well, so they will keep on losing weight. Okay, so the answer to this question would be yes. Then, do you believe yourself to be fat when other thinks you are thin? And this is a very important question, because this is what the main problem the anorexia nervosa patient is going through. They think that they are fat, however, other thinks that they are completely normal, and in real case, they are actually normal. It's just their thought what makes them, believe that they are fat. Okay, and this is the question that would very typically define that a person is anorexic. Okay, so a very essential question that you need to ask. Okay, then the last question, that is the next F, which stands for, do you feel that your life revolves around food? Okay, and the question would be no, because their life doesn't revolve around food. Okay, so this is the scoff question here. Okay, or the scoff questions that you need to ask. And for the three questions, you would be getting the answer as yes, and for the first and the last question, the answer that you would be getting would be no. Okay, so scoff question needs to be asked in the data gathering after exploring the diet. Okay, very very important aspect. Okay, so yeah, I hope that I've covered it in detail. Let's just move on to the next layer. Okay, since it's a psychiatric case, as I mentioned before, the three aspects of psychiatry that needs to be asked, that is number one, the mood. Can you please rate your mood on a scale of 1 to 10? Okay, if you have asked this question over here while you were ruling out depression, then don't ask this question again. Okay, then do you ever feel the need to harm yourself? Okay, self harm needs to be explored, and then hallucinations needs to be explored, that do you see or hear unusual things? Okay, so the psychiatric specific questions needs to be asked nevertheless. All right, then just explore the DESA. Okay, in the DESA, you've explored the diet. Okay, drugs you can ask about, because they may be going through mental illness. Exercise. Okay, exercise, I'm sorry I haven't underlined it over here, but exercise is like really really important. Okay, it is a very very important factor that you need to explore in the case of anorexia nervosa. Why? Because the patient of anorexia nervosa would be exercising heavily. Okay, when you talk about exercise, they would be very excited to tell you about the fact that they go to the gym, they spend hours and hours in gym, and they love doing cardio. Okay, and they would be very excited about and very proud of the fact that they do exercises, and they are going to the gym, and they're very very much physically active. Okay, then you can ask about smoking, and you can just briefly touch upon alcohol. All right, um, then comes the meftosa part. Okay, in the meftosa, you can just ask about the medicine and the past medical history, allergies, family history, occupation. The social history, would be important, because like why not? It's a psychiatry session, and social history is always important in every psychiatry session, and we have seen this, that this is a constant, and we keep on asking this question in every case. Okay, so keep that in mind. But amongst the DESA and Maftosa part, what is the most important thing? Exercise. Okay, exercise need to be asked. Okay, very very essential part of the data gathering. Then comes the anything else. Okay, now a lot of people miss out on this thing, and even though they're able to come to the diagnosis, even though they're able to manage the patient really really well, But just because they're not asking this particular section, they're not asking this particular scenario, okay, they end up losing their marks and they end up failing the session as well. Why? Because as a doctor, fine, you have identified the psychiatric aspect to it, that okay, this is an eating disorder, and the patient is going through something or the other mentally that is that has resulted in a change in the eating habits. That is fine. But what about the complications? What about the medical aspect of anorexia nervosa? Because anorexia nervosa patient, they're not eating anything, they're constantly going into caloric deficit, and the BMI is getting like, is on a free fall, okay, then there is a very very strong possibility that they might be having some medical issues, okay, that needs to be taken into consideration. All right. And what are those medical issues? The patient can experience symptoms like headache and shortness of breath, okay. Then constantly they may feel dizzy, weak, and they may feel some tiredness, okay. Then they may end up developing some gynecological issues like period irregularities, okay. They may go to into amenorrhea because of the lack of their diet, because of their nutritional deficiencies, okay. So you have to inquire about all of these things. All right. Then they may end up developing metabolic disorders like anemia, hyponatremia, okay. So you gotta ask about the questions about these things, and how you're going to ask it. So I would just like to ask a couple of more questions. By any chance, are you having any headache, any problem in breathing? By any chance, are you having any weakness, any dizziness, any tiredness that you may be feeling? And just a couple of personal questions just to make sure that I am understanding your condition in a better way. Can you please tell me, how are your periods? Are they regular? Are they too heavy, or are they irregular? So you need to touch upon the complications of anorexia, because a lot of people they don't, because they just think, okay, we are into the psychiatric aspect, we just need to think about it in terms of the psychiatry angle only, okay, and they just mess up and they just miss out on this important aspect, that is the medical aspect of anorexia, okay. Why is this important? Because let's suppose that if the patient is having any of these condition, okay, any of the complications of anorexia, or when I'll do bulimia, or I'll show you the complications of bulimia, they're more or less the same. But if the patient is having anything of that sort, then this patient would need urgent admission, okay, immediate admission into the psychiatry unit, under the psychiatry unit, okay. If you're studying in GP surgery, if you find these things, uh, refer the patient immediately to the A&E to get themselves admitted, okay. So you need to keep an eye on this, so that the patient can get admitted, you can correct the electrolyte anomaly that might be there, you can correct the anemia, okay, you can correct the nutritional deficiencies, okay. All of it needs to be addressed, and the patient needs to be admitted as soon as possible. All right. And if the patient is having a low mood, or a need to harm themselves, or if they are having hallucinations, okay, then you would definitely have to admit the patient, okay. Now how do you explain it? In very simple terms, you're going to say that, okay, from the chat that we have had and from my examination findings, you might be having a condition of the mind in which a person develops a false perception of their body weight, okay. Just simple definition, that you may develop a false perception of your body weight, and we call this condition as anorexia nervosa. That's it. Very simple, very easy. All right. So before I move on to Bolivia, just a couple of things that I would like to repeat. Explore the diet, explore the scoff, make sure that you identify the psychiatric aspects as well. Make sure that you definitely ask about the exercise, and in the Meftosa part, you try to cover the social aspect, and more importantly, the complications of anorexia. The medical complications of anorexia needs to be addressed. Okay. So yeah, that was pretty much it for the anorexia part. Okay. Now let's just move on to the bulimia. Now, as I told you earlier on, that in the bulimia station, in the bulimia patient, they will be overeating, okay, with a very very strong guilt, and because of the guilt, they'll end up doing those things. They'll end up, throwing up. They'll end up taking laxative. They'll end up inducing the vomiting. Okay, and that is what the problem would be. All right. So the bulimia patient would again, they would not have any insight. So they would be brought by the mother or the relative. Okay. Then yeah, so the complaint that the bulimia patient would show would be vomiting. Okay, most likely complaint that the bulimia patient will have would be vomiting. Okay, and then you would have to take a focus history and manage and address the concern of the patient. All right. So let's just very quickly discuss what the bulimia approach is and what approach you need to take whenever you are suspecting bulimia nervosa in a patient. All right. The first layer is exploring the presenting complaint, which was eating less and weight loss in the anorexia case. In this case, it's basically vomiting. So you're just gonna slightly do the OD para of the vomiting. That okay, how much have she vomited? How many episodes of vomiting has she had? Since how many days she has been vomiting? Since how long she has been vomiting? Is the vomiting induced or is the vomiting, unintentional? And then you just try to, very briefly rule out the possibilities and the other differences. Like for example, GI upset. You're going to ask about does do you have any abdominal pain? Then you may think about, space occupying lesion and central nervous system causes. That okay, by any chance are you having any headache or any difficulty in your vision? Okay, then you may talk about intestinal obstruction by asking about bowel habits, by asking about abdominal pain, or maybe if you're feeling that your stomach is very very hard. Okay, so just couple of questions to rule out 2 to 3 differentials. Okay, just to set the tone and just to explore the presenting complaint very briefly. Again speaking, do not spend a lot of time in identifying and dealing with the presenting complaint. Okay, you have a lot of other things to do in this station. Okay, so just very briefly touch on that. Then again, if the non-verbal clues, like they would be there, and I've talked about that. Okay, how you're going to manage that, how you're going to tackle that, how you're going to make sure that you're providing a safe space to the patient, and how you are ensuring that the patient is comfortable in talking to you. Okay, so after exploring the vomiting, okay, you would directly move on to the cough. All right. Other aspects are like same, but the cough would be something that would be different, because the answer that you would be getting in cough would be slightly different to what you were getting in anorexia nervosa. Okay. So for the question that do you often make yourself sick? Okay, the answer would be yes, because that is what the main problem is, that they're eating a lot and then they end up making themselves sick. Okay, by inducing vomiting, by taking laxatives and all. Okay, then do you feel that you've lost control over your eating habits? The answer would be yes. Okay, and this is similar to anorexia nervosa. Okay, and they would say that yeah, doctor, I've lost control and I'm actually eating a lot, and they would be honest, like that definitely be the case, that they would be eating a lot. Okay, then have you lost more than 1 stone or 6 kilogram of weight in 3 months? Okay. The answer to this can be yes or can be no. Okay. Because they may be just going in a balance. Like for example, if you're eating, let's say, 1000 calories, okay, and then all of a sudden you started going into the regret, and then as soon as you ate it, you just induce the vomiting, and then you just threw everything out. Okay, so automatically, like the food wouldn't be digested, and that wouldn't have been causing a very strong weight gain. So that is the reason why bulimia patients, they are not always overweight. Okay, so the weight loss or weight gain may not be very significantly there. Okay, then do you believe yourself to be fat when other things you are thin? Okay, this may not be the problem with the bulimia patient. Okay, they do not care whether or not they're getting fat or not. They just have the guilt of eating a lot. They feel that it's criminal to eat so much food. Okay, so the answer that they would be given to this question would be a no. Okay, But the main problem, the main cornerstone of the like of the bulimia case, okay, that is that do you feel that your life revolves around food? Okay, this is what the main problem would be. They think that their life revolves around food, and when they start, in consuming the food, they all of a sudden, go into a major regret. Okay, so the answer to this question, the bulimia patient would say yes. Okay, so that is how the SCOF question, the answer to the SCOF questions would be different when you're dealing with an anorexic case and when you're dealing with a case of bulimia nervosa. Okay, so make sure that you are well aware of this cost question here. You know that, okay, if somebody is answering yes to a particular question, what does that mean? Okay, where is it taking me? Is it taking me to anorexia nervosa, or is it taking me to the bulimia nervosa? Okay, so that is something that you need to master. All right. Then the psychiatric aspect, like, would be there again. I'm not going into the details. What are the three psychiatric aspects that we need to cover? Then amongst the days are the diet is important. Okay, they would say that they're constantly taking increased fast food because that is what the problem is. Their life revolves around food and they want to eat outside, they want to take fast food, but then end up, regretting the fact that they ate so much. Okay, so you can just explore the diet by asking about the increased fast food. Okay, then you can ask about alcohol as well. Why? Because just to rule out a differential that, okay, maybe the vomiting is due to chronic alcoholism, but it's a very far-fetched thing. It's just like written there and for the sake of writing it down. But if it's not relevant, then you don't need to go through all of these and like in detail. Okay, the exercise part in the DESA may be relevant. Okay, you may ask, okay, that do you exercise a lot, and they may say that they may exercise a lot as well, but that is not what the coping mechanism is in the case of bulimia. Okay, they don't try to lose their weight by exercising. Okay, that is a natural way of losing the weight. What they do is that they end up making themselves sick. Okay, so you can ask about exercise. Okay, it may be relevant, but you would not get a very important data out of it that you could use in your management. Okay, then the nephrosa, you're going to ask about, are you on any medications? Do you take any medications? And this question is like really important. Why? Because patient of bulimia nervosa would be taking laxatives. And why would they be taking laxatives? So that they can induce a diarrhea, and whatever they've eaten, they can just get rid of it. Okay, by inducing vomiting from the mouth, and by using laxative from the back passage. They just want to get the food out, whatever route it is. Okay, it doesn't matter to them. All right. Then the other part of nephrosa, family history and social history, as I mentioned, it's important. And in the anything else part, again, you got to ask about the complications about headache, shortness of breath, amenorrhea, weakness, dizziness, and tiredness. Okay, the same complications that I talked about in the anorexia case as well. Very important. Why? Because the decision of admitting the patient of anorexia or bulimia nervosa really depends whether or not they have any active medical issues. Okay, so yeah, that is the layer that you need to follow when it comes to the bulimia nervosa case. Okay, it is similar but not same. All right, that is what you need to identify and that is what you need to understand. Okay, yeah. And in the explanation, what you're going to say that you are having a condition of the mind in which a person develops a feeling of guilt after eating food, followed by an attempt to empty the stomach. Okay, this is the way to explain this diagnosis in just simple layman language. All right. So yeah, that is how you're going to explore anorexia nervosa and bulimia nervosa. They are quite similar, but it's a different. Okay, the diet needs to be explored way more in anorexia nervosa. Okay, the answer to the SCOF question would be different in anorexia nervosa as compared to bulimia nervosa, in which you have to explore the vomiting, and the presenting complaint would be vomiting, and the answer to the SCOF question would be different. Okay, There would be slightly different things that you need to focus on when it comes to the days and naftosa in anorexia nervosa and bulimia nervosa. Okay, so very minor difference that you need to know. Okay, do not consider this thing as just one thing, that okay, I'm just going to have one structure in my mind and then I'm just going to differentiate it on the basis of the history. Yes, that is true, the structure is similar but it's not same. Okay, so make sure that you have both the structures in your mind and you know that which one to follow. Okay, yeah. Now, slightly, I'll just slightly touch on the management part. For all the anorexia cases and for all the bulimia cases, okay, the referral that you want to make, okay, is to the eating disorder unit. All right, instead of sending the patient to a nutritionist, to a dietitian, okay, all of those things, just use those one-stop solutions. Just use the clinics that are introduced by the NHS, okay, and the clinic that is relevant in this case is the eating disorder unit. So the eating disorder unit is basically a one-stop solution for all the people with eating disorders like anorexia, bulimia, even patients who are going through binge eating disorders. Okay, what they do is they do the medical assessment, they do mental and psychosocial assessment as well, they offer psychosocial therapy, okay, and they also offer nutritional supports and dietary supports as well. So they've got doctors who are there to do the basic assessment, they've got psychiatrists, okay, who are there to understand the psychology, they've got psychosocial therapists to provide CBT. They've got nutritionists who are there to calculate the caloric requirement and talk about the food that is rich in calories. And of course, the dietitians would be there to make sure that if even if they're gaining weight, they're able to maintain their weight. So it's a one-stop solution, having multidisciplinary team that would help in somehow or the other, would be helping a patient undergoing eating disorders or having undergoing mental health issues regarding to their eating habits. Okay, so just refer to them to the eating disorder units. Okay, that is where the referral would be. Then a very important thing that when you are offering the examination, even before coming to the RMAS protocol, you just in most of the cases you just offer the vital and the GP. Okay, but make sure that in the eating disorder unit cases, you offer BMI and you check for the signs of dehydration, like for example check their knuckles, do the skin pinch test, okay, and examine their eyes, try to look for dry lips and dry tongue. Okay, all of these are the signs of dehydration that you need to look into. Okay, when you're offering examination, a lot of people end up missing on these examination, and unfortunately they don't score well in their data gathering, because these are like really important sign. Okay, if the patient is dehydrated, okay, then again this means that this is an indication for admitting the patient. Okay, so I'll just write it down for you that when to basically admit a patient with eating disorders. Okay, so number one, if the patient has a low mood of less than 4. Okay, if the patient is having suicidal tendencies, okay, you gotta admit the patient. If the patient is having any hallucinations, okay, then you gotta admit the patient. Okay, so this is the psychiatric reasons. Okay, then if the patient is having any medical issues or complications because of the eating disorder, like for example if the patient is having any SOB, if the patient is having any severe headache, okay, if the patient is having weakness or maybe tiredness, okay, if the patient is having any gynecological problem, like for example uh, amenorrhea, okay, all of these symptoms, or if the patient is feeling extremely low, okay, or dizzy, then always offer admission. Okay, So in the first three cases, the admission is because of the psychiatric issues. Okay. In the fourth case, it's because of a medical issue, and another case, if upon examination you find clinical signs of dehydration, because the patient has a very high risk of going into a hypovolemic shock. Okay. And you don't want to send this patient home, okay, because it may be dangerous. And if there is no indication for admission, okay, then you just simply refer the patient to the eating disorder unit by saying that, okay, the eating disorder unit would be a one-stop solution. They're going to talk to you, assess you, and try to change the way that you think about food, try to change the impression that you have about food. Okay. That is what your referral would be. When it comes to the investigations in the IRMAS protocol, you can just order all the baseline investigations, specifically your full blood count to check for hemoglobin, and your serum electrolytes to check for any metabolic causes like hyponatremia and all. The referral is eating disorder unit. In the medical management, you can just talk about multivitamins. Okay. And if somebody is vomiting excessively, you may just want to give antiemetics. Okay. Then the advice aspect, it's just mostly the management is basically the advice aspect. You need to be reassuring, you need to be very supportive, you need to explain this thing that, okay, I would really like to advise you that please avoid taking any laxative, it's not safe for your health, do not induce vomiting. I would like to advise you to change the way that you're thinking. Try to get some healthy food, make sure that you are meeting your caloric requirements. Okay, all of those advices that are related to the eating habits, that depending on anorexia nervosa, that needs to be very very heavily given, because you would be, yes, you would be marked on your investigations and your referral or your admission. Okay. But the more focus would be needed on the advice aspect in this particular case. Okay. Because there is no medicine. Okay. There is no particular drug that you can give to change the habit of how you eat and how you perceive food. Okay. It's the advices and it's the psychosocial therapy and the psychosocial aspect that needs more attention as compared to the medical aspect. Okay. So try to be very very good and very effective on your advices part. And then yes, the safety netting needs to be there about suicide, about low mood, and safety netting about medical complications, the ones that I mentioned over here, about shortness of breath, about headache, about amenorrhea, weakness, dizziness, and tiredness. Okay. So that is how your IRMAS would be, and that is how your IRMAS would vary from case to case. If there is an indication for admission, do not hesitate to offer the admission. Okay, very very important thing. All right. So that's pretty much it from my side regarding the eating disorders. Again, it's a very important topic. It's now, nowadays, it's like a very very famous topic in the exam. Okay, so make sure that you have mastered this. Make sure that you have an idea on how to go about this. And if you still have any queries and any confusion regarding it, drop them down in the comment box below or reach out to my social media. I'll be more than happy to address all your concerns. And if you want a personalized mock with me, then scan the QR code, go to the website, sign up, and then my team is going to reach out to you for more details. That's it from my side. See you in the next lecture.